Joining us today to speak on all things pregnancy is Dr. Abraham Lichtmacher, Chief of Women's Services for Lovelace Health System in Albuquerque, New Mexico, which earned the Women's Choice Award for Obstetrics, Breast Care, and Mammogram Imaging. Dr. Lichtmacher is also the past National Program Chair of the American College of Obstetricians and Gynecologists Hospital Review Program, devoted to promoting improvements and safety in delivering care to women. With over 30 years in clinical practice, he has been involved in research of benign gynecological disease, female sexuality, and hormone treatments. Thank you for joining us, Dr. Lichtmacher.
Thank you for having me.
Let's jump right into it and let's talk about pre-pregnancy. So the term implantation, what does that mean?
Right. The term actually implies the development of the placenta or the implantation of the pregnancy into the uterine wall, if you will. And, normally once the egg gets fertilized, it travels through the reproductive system into the uterus and then implants into the uterus where the placenta develops and ultimately the baby develops. And it occurs, about a week and a half or so after fertility has occurred. Very often the patient will have no symptoms at all. She won't even know what's happening. But on occasion, there is some bleeding that is associated with it. And it's a fairly common occurrence. Probably happens about one time out of 3 pregnancies. So when patients see that spotting, very often it occurs around the time that the patient is expecting her menstrual cycle. So very often it may be confused for a menstrual cycle, and the patient may go on thinking that she had her period and not even realize that she may be pregnant. So the timing is important. But for most women, it is a silent event. They don't even know what's happening.
I see. So that leads me to the next question. How early can someone take a pregnancy test?
Well, our science has advanced so much that our tests, the over-the-counter tests, have become so sensitive that it's getting earlier and earlier. In theory, you can actually detect the presence of the pregnancy hormone before the patient has even missed her menstrual cycle. Although we always caution patients not to get overly aggressive in doing the test too early, because they may get some confusing results and there are a lot of variations in terms of hormone levels and what have you. So typically we ask patients to wait until about a week or so late for their menstrual cycle. That's probably the best time to do it. But the new tests can actually detect pregnancy hormone, which normally should not be there unless the patient is pregnant, as early as about the time of the expected menstrual cycle.
So how does a woman know she's pregnant before she decides, okay, I need a pregnancy test? Because as you mentioned, if the implantation happens and there's some bleeding, which might be mistaken for a period, then what are some of the symptoms that a woman might develop that might cause her to think, maybe I'm pregnant, maybe I should take a pregnancy test?
Well, we always talk about the common symptoms and the ones that everybody sort of reads about and hears about. For one thing, the patient's breasts may feel a little bit more full. Certainly the missed menstrual cycle is a clue. Remember, implantation bleeding occurs in some patients, but not in all patients. So if a patient has missed her menstrual cycle, or the menstrual cycle or the menstrual flow is not quite the way it usually is, it's a lot lighter, maybe a little spotting, and the patient may feel the urge to urinate a little bit more frequently, feels a little bit more fuller, a little bit more bloated. And sometimes, and not always, patients begin to develop a little queasiness, the so-called morning sickness. That usually occurs a little bit later on, but all of these things, in general, the patients will feel a little bit different. They'll feel more fullness in their chest as the most common symptom. And that's a time that says, hey, something is off. Maybe I should look at, doing a pregnancy test or finding out whether I am indeed pregnant. And of course, if the patient is trying to get pregnant, that would be a good source of suspicion.
I see. So now I took my pregnancy test and I know I'm pregnant. And I think the next thought, and of course, the next concern is this going to carry through? Or could I have a miscarriage? And if so, what are those warning signs?
Sure. The most common warning sign of miscarriage is some bleeding and some associated bleeding. And once again, it gets a little confusing because bleeding can occur even in a normal pregnancy. But bleeding that is associated with some cramping, it's increasing in intensity, that's one of the earlier signs. But I caution patients not to overread into those signs because, as I mentioned, it happens in a lot of early pregnancies. The other sign is that, the fullness in the breast, the things that we typically associate with pregnancy, the things that makes a patient go do that pregnancy test, it's just not progressing as much. And in fact, the patient feels my breasts aren't as full, I'm not as squeezy as I was before. Those are some of the earlier signs of the pregnancy, maybe not completing it. We call it failed pregnancy. So those are some of the things that you watch out for. But I want to take you one step back, if I may. And I think the most important criteria in terms of miscarriages or not miscarriages is getting yourself ready for the pregnancy before you even start planning for a pregnancy. I think that pre-pregnancy planning is critically important. You want to get yourself in the best shape you possibly can, get rid of some of those bad habits, the smoking and things of that nature. If there's a little bit of a dietary issue, if you want to drop a few pounds, that's the best time to do is before you get pregnant, not after the pregnancy. Once the pregnancy has occurred and you're dealing with the pregnancy is going to continue or not, the unfortunate reality is that Mother Nature is not a very efficient sustainer of pregnancies, and about 1 out of 5 or 6 pregnancies, unfortunately, will end in a loss of that pregnancy. So it's a fairly common occurrence. One of the things that I mentioned to patients, and I think it's a very critical point, the most common thing the patient feels when, unfortunately, a pregnancy does not continue is, what did I do to cause this? How could I have prevented it? And the reality is, in most cases, you cannot prevent it. And in most cases, I try to alleviate the patient's sense of guilt, if you will, by telling her there's really nothing that you could or could not have done, and there's nothing that you did that caused this. Whether staying off your feet or not lifting that extra bag of groceries, that probably did not cause the miscarriage if it is going to occur. But so that sort of take a step back a little bit and look at the whole picture.
So speaking of what you should do and shouldn't do, and how to get ready, how to get your body ready, but during pregnancy, should you stop exercising? Should you start exercising? And what kind of exercises would be probably most beneficial?
Well, I actually tell patients to continue their level of activity. You don't want to start something that's dangerous. And I sort of kid my patients here in Albuquerque. We've got the mountains, so some people may go skiing. And I tell them, if you're a skier, keep skiing, but don't ski quite at those expert and daredevil slopes. Just take it down a little bit take it one notch down. But you really want to maintain a level of activity that you're used to. Patients who are very active, who continue doing aerobic activities, they can continue doing that. May want to taper it off a little bit towards the end of the pregnancy, but they want to maintain that level of activity as much as possible. And the other thing we always talk about is the good nutrition. I tell patients to really balance their diet. 3 bags of potato chips is not a good balanced diet. So I tell them really balance and eat fruits, vegetables, sort of the corny things, but they really do work. So if you want to start an exercise regimen, probably the easiest and the best to do is just simple walking, because everybody can do the walking part, and it doesn't strain the patient too much. You want to be cautious about overdoing it and injuring yourself, which may be a little bit more difficult to recover from an injury during the pregnancy.
I understand. And what about those cravings? What do those mean? Is it that the body's lacking something, some vitamin, some nutrient?
Oh, I wish I had the answer for that. After 30 years of doing this, I still can't figure it out. All it means is you're going to be going out there looking for things that you normally don't eat. I don't think anybody really knows for sure what the cause of that is. If you're having a normal nutrition, if you're eating normally as you do otherwise, your body will provide generally most of the things that the baby will ultimately need in terms of nutrition. As I mentioned, balance in your diet is important. We often do recommend some vitamin supplementation because sometimes diets may be lacking in certain vitamins. But the B complex vitamins and iron are probably the two most important supplements that patients will want to get during their pregnancy. But as far as cravings, I wish I knew the answer to that. Unfortunately, I don't think anybody really does.
So let's hope that every woman that gets pregnant has a wonderful pregnancy, which culminates in a beautiful labor and a beautiful baby, or an easy labor and a beautiful baby. But sometimes, unfortunately, there are complications. So let's talk about some of them. What is, for instance, an incompetent cervix? And what can that lead to in terms of if you're pregnant?
Well, in the simplest terms, if you think of the anatomy, the cervix is the neck of the womb that maintains, it's closed during the pregnancy and then relaxes and opens up during the process of labor. An incompetent cervix is one that is not able to maintain that pregnancy in the uterus. It opens prematurely. The ultimate result of that, unfortunately, is an early delivery or a loss of the pregnancy. There are a lot of concepts about incompetent cervix that have changed over the years and how to manage it and how to treat that. Some people have always thought about in the past putting a special stitch or a cerclage stitch around the cervix. That concept has changed a little bit, and we're really not sure what the proper management technique is for that. One aspect of an incompetent cervix, though, is it doesn't suddenly happen out of the clear blue for most individuals. It is something that occasionally is a complication or a long-term complication of past surgical intervention on the cervix. There are a lot of surgeries that are done on the cervix for appropriate indications. They may lead to an incompetent cervix. And unfortunately, also, you may not know it until the miscarriage has, or a later miscarriage has already occurred, or an early premature delivery has occurred. So that with a subsequent pregnancy, we already know the patient may be at risk for that particular complication. In general, it tends to be a relatively rare complication. So for most people who are pregnant, especially for the first time, it's usually not something that we would be very concerned about unless there's some specific history that the patient is given about past treatment. And I think you bring up a good point in regards to when you ask about incompetent cervix, and it's just a generic comment. It's important for the patient to get in to see her obstetrician fairly early in the pregnancy so that they may go through the patient and her obstetrician all the different risk factors, a lot of things that we can identify and determine whether the patient is at risk for some of these things. And the best time to do that is early on in a pregnancy or even before the pregnancy, and then try to create a plan of care that may alleviate or reduce some of those risk factors for the patient. So get in to see your obstetrician as early as you possibly can.
Understood. What is an ectopic pregnancy, doctor?
Ah, so, we talked about the pregnancy, the egg being fertilized and then traveling through the reproductive tract and ultimately implanting in the uterus. And the uterus is where that pregnancy will develop and grow. For a variety of reasons, the pregnancy that does not reach that uterus and starts to develop outside of that uterus, and the most common area for that is actually in the fallopian tube. That is an ectopic pregnancy, a pregnancy that does not develop in the uterus or in the wrong place. It is a relatively uncommon occurrence, although there are some patients who may be at higher risk for it. Patients who may have had previous fertility surgery or previous tubal surgery, actually patients who may have had a previous ectopic pregnancy are at higher risk also. And the rates of how often this happens really deals with patient populations where there's a higher risk of pelvic infections. That may increase the risk also. So it could occur anywhere from 1 in 80 pregnancies to more commonly 1 in 200 pregnancies. The ectopic pregnancy in and of itself, and there's one aspect of it. Occasionally I have patients who say, well, I don't want to deal with any complications, but this is potential life-threatening condition for the mother. That pregnancy that's developing outside the uterus cannot develop appropriately in a fallopian tube or even rarer cases in the abdominal cavity. That needs to be dealt with in the past traditionally surgically, but more often nowadays when a diagnosis is made early on, it can be treated medically. And that is not a pregnancy that can be sustained or maintained and certainly has a potential life-threatening risk to the mother's health. So it's important for those patients who may be at risk for an ectopic pregnancy to work with their obstetrician to determine that the pregnancy is actually indeed located where it's supposed to be in the uterus rather than outside the uterus or in an ectopic location.
And that would be determined when the patient visits the doctor.
Yes, and the doctor will make the assessment based on examination of the patient, based on history of the patient, and also very often an early ultrasound will be performed to determine the location of the pregnancy.
What about preeclampsia and eclampsia? Can you talk about those complications and what's the cause of it?
Sure. The term preeclampsia is really a spectrum of conditions that are characterized by hypertension and hypertensive disorders of pregnancy. So it's a blood pressure issue. We don't really know what causes preeclampsia. I mean, there are a lot of theories, a lot of research has been done, but we simply don't know what ultimately causes preeclampsia. In the old days, about 1,000 years ago, we used to call it toxemia of pregnancy, and the thought was there's some kind of a toxin or poison that was circulating through the mother's system that caused it. We know that's not the case nowadays. So the term preeclampsia refers to a very common specific type of blood pressure disorder, usually occurs late in the pregnancy, towards the very end of the pregnancy. It's characterized by increasing blood pressure and some other derangements in the chemical processes of the body. If this tends to be a progressive disorder, so in other words, if it gets worse and worse and worse, the patient may ultimately lead to a secondary complication of that with convulsions and seizures, and that's fairly concerning for patients and for the safety of the mother. When the patient does suffer the convulsions and/or seizures, that's called eclampsia. So there's a progression of symptoms. The treatment really is trying to manage the potential for maintaining the pregnancy and ultimately is delivering the baby, because once the baby is delivered, a lot of the changes that occur with preeclampsia tend to reverse themselves. So the danger time is actually up until the baby is born and shortly thereafter. We know that about 10% of patients are going to have some form of a complication related to blood pressure issues, and we can identify certain risk factors for that. There are some conditions and the increased risk factors for developing preeclampsia. But ultimately, the bottom line cause of it, we don't know. We can simply identify the potential complications and deal with those possible complications.
And what about gestational diabetes? What is it? How can it be prevented? Does it go away after pregnancy?
Well, we're all familiar with diabetes. It's becoming increasingly more common in the general population. I think it probably has to do with all those extra calories that many of us put on, and it may have to do with our diets. And gestational diabetes is actually diabetes that develops during the pregnancy. There are standard recommendations now. We actually screen patients about midway through the pregnancy for the potential of gestational diabetes. Once again, we know that some patients may be at higher risk if there's a family history of diabetes. Patients who may be somewhat overweight may be at higher risk. Patients who are carrying twins may be at higher risk. There are a whole sort of other types of potential risk factors. So we screen patients for the developing of diabetes in pregnancy. The problem with it is that ultimately, if it's more significant, if the diabetes has a higher derangement of sugar, the body's ability to maintain sugar balance, what happens is you develop complications both for the mother and the baby. We talked about preeclampsia a few minutes ago. Patients with gestational diabetes are at higher risk for developing preeclampsia. We also know that babies' growth patterns change, and a lot of patients who have gestational diabetes will tend to have babies that will grow to be quite large. And I tell patients, if you have a 12-pound baby, that's not necessarily a source of pride. That's a potential difficulty in a delivery. So we want to maintain as good a sugar balance or as good a control of the sugar during the pregnancy, try to remove some of those possible risks. Most people, the gestational diabetes will clear away after the delivery, after the hormones of pregnancy have left the body, that will go away. but it may be a harbinger of a patient's future history. And a percentage of patients will actually develop adult onset or type 2 diabetes later in life. The ones who've had it during the pregnancy, that may be a sign that you may be at risk for later in life. So again, watch your diet, exercise, good nutrition. We'll try to control some of those possibilities.
Okay, so let's talk about labor and delivery. What are some of the preterm labor symptoms?
Well, the most common one is patients talk about are cramps and or contractions, and sometimes it's difficult to determine whether it's a contraction or a cramp, and that's the one thing that patients feel, and they often will come to the doctor's office to be evaluated for possible preterm labor. But the reality is that most patients who are cramping and most patients who have contractions during the pregnancy actually don't deliver early. They deliver at full term. And if you think about it, our ultimate goal is whether patients contracting or cramping is to actually have them deliver at full term, not to have that baby come too early where there's a lot of other potential complications for the baby. So most common symptoms for the patient is cramping, contractions. Occasionally, there's a little bit of spotting, occasionally an increased vaginal discharge. I think if there's a little bit unclear as far as what's going on, the best thing to do is get assessed by your practitioner, get assessed by your obstetrician to be certain whether anything is going on. And the ultimate sign of true preterm labor is if that cervix, we talked about the cervix very early in this interview, if that cervix begins to open up, it starts to change, it starts to thin out. We call that effacement. If there are cervical changes associated with contractions, that may be a true sign of preterm labor.
Is it normal to have a bowel movement during labor or for the baby to have a bowel movement? I believe it's called meconium.
Yes. So two separate things. The first one is normal to have a bowel movement in labor. It happens occasionally for the patient as she's pushing during the second stage of labor and the baby's head comes through, sometimes for stool to come through. In the past, patients were often subjected to a variety of preparations before they actually delivered. They were given an enema and they were given shave the pubic area. And we found that's really not necessary. And I think those are outmoded, old-fashioned techniques nowadays. So the stool, if it happens, it happens. You know, obstetrician will usually take precaution of making sure the baby doesn't get contaminated with that. Now, the baby passing stool called meconium, that does happen. It happens in a percentage of patients. It's a reasonably common occurrence. We sometimes think that it's the baby's way of telling us something is going on and maybe a response to the intrauterine environment. And on occasion, it is a sign that the baby may be having some difficulty in the uterus. But because it happens so frequently, it becomes a sort of a common occurrence. And the most important factor for that is to recognize, for the obstetrician, to recognize are there any issues that may be causing this baby to pass meconium in the uterus and alleviate some of those stressful conditions if those are the causes of it. Ultimately, the baby is going to be swimming in this meconium. And in fact, if the meconium stains the amniotic fluid, remember the baby continuously swallows amniotic fluid and passes through its system without any difficulty. But it's a time of birth that the baby may actually, when it takes its first breath and inhales its first breath, if it inhales meconium into its lungs, that may be a bit of a problem and it can cause some difficulty for the babies. There have been a variety of recommendations made on how to deal with meconium stained fluid at the time of delivery. The concepts have changed a little bit, and I think we now look at what are the risks for the baby actually inhaling that meconium. Is it in the baby's mouth? Is it simply the fluid that's stained? Very often, the obstetrician or a pediatric attendant who may be present for the delivery will make sure the baby's mouth is clear so there's no meconium in the mouth that can be inhaled as the baby is born. Again, it happens so frequently that it becomes a very routine process for us to kind of deal with it at the time of delivery.
And so let's talk about induction. When does it happen? When does it need to happen? When does a mother or expectant mother need to be induced? And what are some of the risks and, of course, advantages of that?
Well, an induction of labor simply means that you're inducing labor before Mother Nature has had a chance to start the process. And the question always comes up is who is smarter, Mother Nature or the obstetrician and or the patient making that decision? Typically, we say that it really should be a medical indication for an induction of labor. And the medical indications could be a variety of things, whether the mother's health may be in jeopardy, whether the baby's health may be in jeopardy from continued pregnancy. So if there's a determination that continuing the pregnancy beyond a certain point is detrimental to the health of the mother or the baby, an induction of labor may be indicated. All too often, though, people have taken the step of, "Hey, I'm going to induce the labor because I'm simply tired of being pregnant," or it's a timing issue. I need to get delivered this weekend because next weekend we're doing something else. So we really try to stay away from that. Um, and typically, what we do want to make sure is that if there's no medical indication, if it's one of those timing issues or elective, if you will, and no medical indication, that at least the patients wait until the pregnancy is considered full term mature enough. And the concept of what is mature really has changed over the years. And now we actually want that pregnancy to get to be at least 39 weeks of gestation before any elective processes are undertaken. More recently, there have been some reports that have looked at what is the optimum time for the patient to be delivered or induced into labor. And there's a big debate going on still in the medical circles whether it's best to leave the mother alone, let the natural process occur, or is it better that we induce labor at a certain point because it may be safer ultimately in the long term for the mother or the baby. You asked about the question of what are the risks of the induction of labor. And historically, we would talk about the risk of inducing a patient into labor would potentially increase the possibility of a patient winding up with a cesarean birth simply by the fact that the mother's body is not ready for that labor to be induced, and whether the labor is a longer labor and what have you. And again, more recent reports have called that all into question. And there's a big debate now that actually is going on as to whether inducing labor actually does create a longer labor or does increase the cesarean births. I think that the answer and the question still has not been fully resolved to be able to say definitively, yes, you can induce somebody into labor and have the same outcome. We also look at how is the mother's body prepared for the labor. How low is the baby in the birth canal? Is the cervix open or is it thinned out, effaced and dilated? We do an assessment to see what is the likelihood that if we induce the patient's labor, that her chances of successful vaginal birth are going to be the same as they are with a spontaneous, naturally occurring labor. So that all should be going into the calculation, the assessment of the patient, and discussion with the patient and the obstetrician. It should be a mutual shared decision-making process, not just one way, one individual making that decision.
When your water breaks, should it have a clear color? If it's brownish, what does that mean? Should you be worried?
Amniotic fluid tends to be clear. In general, it tends to be clear. We spoke a little bit about meconium fluid. Meconium stained fluid will tend to be a little bit on the greenish side. I suppose someone could describe it as being brownish. So if you have that discoloration to the amniotic fluid, there's some word of caution you need to kind of assess it as to what's going on. The other possibility is there may be some blood tinged in the fluid. Now, a little bit of a blood in the amniotic fluid is not a cause for concern. There is a little mucus that passes, and sometimes that's coated with a little blood. But a heavier staining of brown may indicate old blood in the amniotic fluid, or more active bleeding. A bright red blood may indicate an ongoing process. And I think that should be evaluated relatively promptly by your healthcare team. So normally the amniotic fluid will be clear. And I tell patients, because sometimes it's difficult for the patient to tell, is it truly the amniotic fluid, particularly if the water breaks in sort of a slow trickle rather than a big gush of fluid. And I tell patients it's like peeing in your pants, but you can't control it. So if you have enough fluid, it's running down your legs into your shoes, it probably is the real thing. And good idea to get in touch with your hospital or get in touch with your obstetric providers.
You spoke earlier about C-section. So, what determines whether a woman should have a C-section instead of a natural birth or natural delivery?
Well, we always strive for a natural delivery. It's the easiest on the mother's body. It's the safest. There are fewer complications with a natural birth, and so it's the sort of default method of delivery. However, there are times when a C-section is indicated, and again, these are generally times when the decision is determined that the health of the mother and or the baby is potentially compromised by either waiting longer or an extended labor. There are various indications for C-section. Most commonly, the decision is made in labor. Again, if the baby's not tolerating labor, or if the labor is extended for a lengthy period of time and the baby's not descending in the birth canal properly. But all too often nowadays, when a C-section is performed, subsequent to that, the patient going through a second labor starts thinking about, hey, is it just easier for me to deliver by C-section? And timing is easy, everything is easy. But still, the risk of cesarean birth, remember, it's a major surgical procedure. So the risk of cesarean birth is still higher than it is for a vaginal delivery. And we almost always recommend a vaginal delivery. So even for those patients who've had a previous cesarean birth, in many cases, it is safe for that patient to attempt a vaginal birth. There's a way of calculating about what are the likelihood and the chances of a patient successfully delivering vaginally versus ultimately winding up with another cesarean birth. And again, you can make that joint decision. We try to stay away from sort of electively doing things by doing something that's more risky for the mother and or the baby just for convenience factors. So, but there are some situations where cesarean is absolutely mandatory. There are certain complications in pregnancy that contraindicate a vaginal delivery. Things such as placental complications. The placenta actually develops below the baby at covering the cervical opening. It's called a placenta previa. That really is a contraindication to a vaginal delivery. So again, education and discussion with the obstetric provider.
So, quickly, I'm just going to go through some myths. I just want you to tell me if it's true or false. Should pregnant women get rid of their cats?
No, not necessary. The myth actually has some basis in fact. Many cats, particularly cats that are outdoor cats that hunt, pick up an infection called toxoplasmosis, and they actually carry it in their system. It's passed through their digestive tract. It's in the stool of the cat. So the patient who's dealing with the litter box may actually pick it up, ingest it. For most of us who've had cats, we may have been exposed in the past, may have had toxoplasmosis in the past. It generally tends to be innocuous. However, if a patient gets exposed and gets infected in the pregnancy, that can be difficult for the developing baby. The reality, though, is for most individuals who have a cat, particularly an indoor cat, it probably is not an issue. So they don't have to get rid of the cat, particularly a family member.
Okay, another one. Is it safe to take over-the-counter cold medications during pregnancy?
The answer is for most situations, yes, but a little bit of a caution. I tell patients, minor aches and pains, Tylenol is probably okay to take. We usually want to keep patients away from ibuprofen type products. The cold preparations, most of the things are safe to take. I do always recommend that patients talk to their obstetric provider so that very often the obstetrician or the obstetrician's office will provide a list of things that patients can take over the counter without any recommendation from the physician's office. But if you're unsure, if it's unclear, best thing is just find out and call and get the answer.
And if you have lots of heartburn during pregnancy, does that mean your baby will be born with lots of hair?
I've heard, our grandmothers used to tell us that, but I have to say that I've had patients that live over the last 30 years. Some of the babies had lots of hair, and the patients barely knew that they were pregnant. So I think that's truly an old wives' tale. So I don't see any correlation. Besides, ultimately, that hair gets lost in any of us. So it doesn't make any difference. I don't think it makes any difference at all. I have no idea about that.
Thank you, Dr. Lichtmacher.
I just want to thank the Women's Choice Awards for having us receive the recognition in obstetrics and breast care and mammography. We always, as dedicated professionals at Lovelace particularly, we think we always want to put the patient at the center of our practice. We always want to do what's best for the patient, and jointly we always think we're the best at any rate, but it's always nice to have an outsider's recognition telling us that we're doing a good job. So I want to thank the recognition that we've received, and thank you, Women's Choice.
I'm sure it's well deserved. And again, thank you. Thank you for spending this time with us and giving us such valuable information.